Hello, good evening, everyone. Welcome back to my MVF&x, the European Fertility Society. We are back once again today, and I'm really happy to see you all here. Thank you for joining us tonight. Dr. Elias Tsakos is with us already as well. Dr. Elias Tsakos has been our presenter for many years and many topics, and I'm really happy to have you back. How are you? Great to have you as always.
Hi, Caroline. I'm wonderful, thank you, and can't wait to give my patients and the viewers all the latest evidence on PRP.
That's great topic to discuss for sure, and I'm sure you will have plenty of questions. So, as always, please remember to put those in the chat. Dr. Tsakos will definitely answer them for you right after his presentation. First, we will discuss PRP, what it is, and of course, the Dr. Tsakos will be happy to answer your questions right after his presentation. Just let me remind everyone that Dr. Tsakos is the medical director at Embryoclinic in Thessaloniki, and you've been our guest speaker, as I've mentioned, for many years. So it's always great to have you. And yeah, thanks everyone for chatting here. And of course, we are here to simply discuss the PRP. But before we do, let me just briefly introduce our new program, which is called Patient-Centered Care Clinic Program. And this is a certification that this is the first certification in Europe where it focuses on patient-centered care. And I'm really happy to actually say that one of the recipients of this certification is actually Embryoclinic. So you've received this year, and we are really happy that you are able to go through the process and you fulfilled all the aspects of it and you were able to receive it. So I just wanted to briefly tell you about it. And for more information, as always, please go to 𝐬𝐮𝐬𝐫𝐞𝐿 and you will be able to find out a little bit more on how it works and how you can actually see which clinic already has received this. And now I don't want to keep you waiting, so let's go ahead with our presentation. And please remember, you can type the questions in the chat right now or afterwards as well. Thank you.
Sure. Thank you, Caroline. I will try and keep it short and sweet. I will be speaking for about 25 minutes, and then we're going to have another 25 minutes for questions. Before I start, I would like to give you a little bit of my perspective with regards to new treatments. My perspective is very clear. My team and I, we keep monitoring all the updates in our fields of interest, and particularly in fertility. But I mean, for that purpose in surgery and other areas as well. I have a team of about 35 scientists who daily look into the latest evidence and the latest updates on all the new treatments. Now, when we are convinced as a department, as a unit, as a team, about the possibility of those new innovations being proven and being applicable, then we go into the phase 2, which is to meet the pioneers in the field, discuss with them. Invariably, we visit their facilities. In order, I personally make the visits with members of my team, and to discuss some practical, logistic, clinical, scientific, safety, and success aspects. Following that second round, then we design our own protocols and we implement those protocols. We're always very cautious, especially when it comes to new treatments. So we don't experiment on our patients. We would only apply new treatments when there's enough evidence to prove that A, they're not harmful, B, they're safe, and C, they're potentially positive. And of course, this is a process that's been going on for the last 26 years in Greece. Some people call us pioneers. I don't think we are exactly that. I think we are the second stage after the pioneers. We are early adopters. My team and I, we like to adopt early the work of pioneers all over the world. And through this process, we have been privileged to meet those amazing people who have pioneered amazing methods all over the globe. So this is our approach. And with regards now to platelet-rich plasma treatments, my team and I have been studying and have been following the evidence for the last 10 years at least. And only in the last 2 years we have been convinced that although the evidence is not overwhelming, although the evidence, and this is beyond the scope of today's presentation, is not black and white, is not there, we believe that PRP treatment may be effective in a select group of patients. So we've started using that technology in the last 2 years. We started with endometrial PRP, where the evidence is a little bit more clear, is a little bit more straightforward. And of course, with ovarian PRP, where although generally the scientific community is very guarded, and I will explain the reasons why, so are we. You know, we're not selling this as a treatment for all and treatment for everyone. You know, this is not the case. However, in select cases, this approach may give us some benefits. So this is where we are at the moment. So at the moment, I believe that with endometrial PRP, there is more clear evidence. Actually, the European Society of Human Reproduction 2 years ago included the PRP treatments in the pre-Congress courses, not directly approving or allowing this treatment as universal, but indirectly it has shed some light on this approach. So we're talking now about ovarian PRP. In other words, the potential effect of injecting platelet-rich plasma, which is autologous. These are amazing Greek words, which is derived from the patients themselves into the ovaries in the hope to improve the function of the ovary. To be honest, I'm not sure I like the term rejuvenation. I think it's probably a little bit too optimistic. It's a little bit too plastic surgery and too lifestyle type. I would say for improving the ovarian function. So I will take you very quickly through this concept. So this is what I'm going to talk about today. I will go fairly quickly. What is PRP? Platelet-rich plasma is an autologous, is a product produced by the patients themselves. We can all produce PRP. This is from blood. It requires a special preparation. It took my team over a year to standardize the protocol in order to achieve the optimized results that we wanted to achieve. And then there's no extra medications or substances at the moment in our program being used. Having said that, there is research in various parts of the world in order to understand if the addition of some extra factors would make a difference. We're just scouting for the evidence at the moment. And then we infuse, we inject that fluid into the ovaries. How do we do this? If it's possible, technically vaginally, similar to an egg collection. Instead of collecting eggs from the follicles, we inject this plasma into the ovaries. And if it's not possible, I will explain the difference, then we do it through laparoscopy, so through keyhole surgery, if you like. Generally, it's a safe procedure. I have to say that it's being used in many other medical specialties. And of course, reproductive medicine is the new application, the new kid on the block. Platelet-rich plasma has been widely used by aesthetic surgeons and physicians, and also by orthopedic surgeons for the athletes. But of course, the physiology, the application is totally different there. So schematically, you can see how this is being done. This is the female reproductive system, the vagina, the cervix, the uterus, the tubes, the ovaries. So through the probe, we aim for the ovaries in order to do that. It's not a very straightforward procedure because invariably we're talking about small ovaries, atrophic, sometimes climacteric, with very few, if any, follicles. many times mobile. So technically, it's not always feasible. It does require the skill of an IVF specialist, and also compared to the laparoscopic approach, has some disadvantages. Personally, I'm not as happy as I am through laparoscopy, but of course, it's a much easier procedure for the patient. So I have to weigh the advantages and disadvantages of the procedure. Generally, I always prefer as a first option to go for the vaginal route, but I feel more confident with the laparoscopy route, which not only is it safer overall because you see the ovaries, you're very certain about the areas and the injection sites, about the depth of the injection and so forth, but at the same time you can perform a fully diagnostic laparoscopy to exclude other conditions like adhesions, endometriosis, etc. So I think the route has to be discussed individually with its case, separately. So the abdominal route is here, and as I mentioned, it can be combined with a full diagnosis of the internal pelvic organs of the woman. We can see it very nicely here. So that's that. If we go further down, the timing, there's various theories, and this is where the whole variability starts. Some people time it at some stage in the cycle. Some other scientists believe it doesn't matter. I believe if we can't always time it. Perhaps if we can, perhaps the first half of the cycle may be best within the first 14 days. But having said that, most people don't even mention in the studies when they have done that, and if they do, there's a lot of variability. How is this produced? Straightforward. We draw some blood from the vein, we centrifuge, and of course, there's a lot of secrets here. I'm very happy to share our secrets to any medical doctors or fertility personnel. And the whole idea is to extract the platelet-rich plasma after that. We need to avoid using blood because blood can interfere, like red cells. They can interfere with the function of the platelets. And of course, we need to make sure that we know what we're injecting in terms of clarity, in terms of lack of infection, and in terms of density. And that's why in our department, we always do quality control so that we know what we've injected and to ensure that this has been 100% clear. Here you can see those tubes after the preparation has taken place. Now, how does it work? I'm not going to bore you with a lot of details, but the whole theory is that platelets, they have substances that contain a lot of useful proteins. In other words, they're rich in peptides, in growth factors, and also in anti-inflammatory cytokines, substances. And of course, we know only too well that platelets are the repairing mechanism of the body, so they can improve cell proliferation, tissue healing, the production of new vessels, and also the modulation of the immune system. Okay. Let me just sort out my slides here. So the effect on the ovary, various effects. I'm not going to bore you with theory. One is through the improvement of blood supply. The other is the improvement of the environment in which the follicles grow. And there is, of course, some scientific evidence here. In 2024 has been a busy year. There was a lot of meta-analysis, a lot of studies trying to shed some light in that. And of course, one of the main outcomes that have been measured is how does it affect the AMH levels. We all know only too well that AMH is the ovarian reserve hormone. So platelet-rich plasma seems to increase the AMH levels. Within a couple of months, in some cases in 3 months, there's increase in the number of antral follicles, which are the potential follicles that may produce eggs. And of course, in this study, it was shown that there's 1.5 more oocytes following the treatment. There's less cycle cancellations due to poor response, which is always a good thing. And there was about 1 more normal embryo produced after this technique. So these are the benefits manifested in this particular meta-analysis of 2024. There have been more with similar results. I have to stress here that all the studies included, they were not what we call top quality studies. You know, the evidence is there, but it's not top quality. However, there seems to be a trend towards accepting that it doesn't harm it. It's probably useful. Now, what we are called to do, of course, is more studies, more good quality prospective studies, perhaps multi-center studies. And at the moment, we have a couple of protocols running in our clinic. We're, you know, shouting out to collaborators and doctors across the globe if they want to combine some of our evidence in order to produce better quality controlled randomized prospective studies. I am pretty confident that this will happen in the next few years. And with regards to the outcome, I cannot predict exactly, but I believe that what we're all trying to figure out is which is the subgroup of patients that would benefit the most. I have some suspicions. I have some evidence from our unpublished data at the moment that you know, some patients may benefit more than others, and I can share that with you. That would probably be the younger patients, with regards to fertility, of course. The younger age group, perhaps the age group below 43, and in particular the healthier age group, women who have been investigated. They have no karyotype or DNA anomalies. They have no serious immune defects or hormonal defects, and they have, until now, what we call idiopathic infertility. And certainly the women who are before the menopausal state. So, you know, in our initial data, it seems that it's probably unlikely for menopausal women to be benefited by this technology. So what about, you know, we have to be careful in how we interpret the results and in how we position ourselves you know, in front of this treatment. I do not agree with some centers that advertise PRP as a panacea, as one method that fits all. I don't think that's the case. I think we have to be very, very guarded. Yes, it may be an option. It may be a valid option before egg donation, for example, for women who have tried everything else, but under no circumstances is it a panacea for everyone. So I think we have to be very, very careful, and we have to look out for ongoing research, trying to understand exactly what is going on. So endometrial PRP, you can scan this QR code. I think there's more evidence at the moment. And again, we have data within our department, unpublished still, with good effect on the endometrium, especially in women with previous failed IVFs, with thin endometrium, with multiple surgeries, hysteroscopic surgeries on the endometrium. Sometimes, of course, women with adhesions or women with 𝐟𝐨𝐫𝐞 syndrome and all that. I mean, the endometrium is a more simple tissue, you know, I think there's more evidence that the theory is more likely to work there. The ovary is a much more complex issue, and let's not forget that we're not treating the AMH. We're trying to produce competent oocytes that will produce good quality embryos and eventually a healthy child. So if you want to scan this code, feel free. So to summarize, PRP is an autologous blood product that has been safely and successfully used in many medical fields, including fertility, and that's been going on for more than 10 years. It induces cell proliferation and improves vascularization, the production of new veins and vessels, and the blood flow in the ovary. The procedure is generally simple, flexible, inexpensive, and can be combined with other procedures to reduce cost and exposure to surgery. I have to say here that one of my favorite timings for PRP is during or just after an collection of poor responders, when I have received 1, 2, 3 follicles, 1, 2, 3 eggs, or no eggs. Sometimes when the ovary is a little bit stimulated and vascularized, it's technically much easier to introduce the PRP and, of course, hope for the next cycle to be more productive. However, the reproductive outcomes at the moment have not been very impressive, and that's why the scientific societies, they do not endorse that as a standard clinically applicable add-on. However, I believe that it is our responsibility as treating doctors to identify potentially suitable patients and offer that as without seriously high hopes, and offer that as a possible alternative before we resort to egg donation to some of our patients. I mean, I can see a couple of people of my team. Hi, Stephanie. Hi, David, in the audience. So I can quote our experience of this week. We had a 46-year-old lady who gave us 7 eggs, and 6 of them fertilized, having had very poor response prior to that. I think that's an exception to the rule, but I cannot fail to mention that that was after PRP treatment on the ovary following an unsuccessful cycle 3 months ago. So perhaps we haven't identified the ideal candidates for that, but since the technology is there, it's fairly safe. With guarded optimism, I think we should be at least discussing the possibility of offering that to our patients. That's it for me. I think I'm within my 25 minutes. This is the latest literature. Most of those papers are of 2024, so very recent. So please, if you want to look into the original papers, feel free to take a screenshot. And I would like to finish with many thanks to my team for supporting me in all those activities, for backing me up, backing our patients up, and of course creating the time for the scientific members of our team to gather all the information for our patients. Thank you very much. So
let's take a look at the question from Dana here. So can the effects be seen after just one PRP treatment or after multiple treatments needed? And how long do the effects of PRP usually last? Is it better to have a multiple attempts?
Sure. Given the lifeline of the follicles, I would expect the maximum effect within 3 months, within 90 days. Excuse me. Oh, sorry. Thank you. Basically, there's a lot of research now showing that AMH is being increased 1 month after, 2 months after, 3 months after. So I don't think that it has to be repeated at least sooner than 3 to 4 months, and I would expect the maximum possible effect within 3 months. Let me be clear. I have never done it twice. I've done it twice a few times. When I was not satisfied with the vaginal route, and then I opted for the laparoscopic route. And in fact, in half of those patients, I discovered endometriosis that was undiagnosed before. So, to be clear, I don't think there's any particular benefit in keep doing, for example, vaginal PRP treatments. I think one is enough. If we're happy technically, and if the quality control is telling us that the concentration of platelets is reasonably good, and in my opinion, reasonably good is anything between 800,000 to 1.5 million per microliter. And if we're happy with our technique, sometimes it's not possible to confidently puncture the ovary. Sometimes the access is not brilliant. We're not in the right place. You know, if we're not confident about any of these factors, that will manifest itself by not increasing AMH levels. Then I may repeat it through the laparoscopy. But otherwise, if I'm happy, if the procedure has been done nicely, if the AMH is increasing, I'm more than happy to keep doing IVF cycles back to back, or alternating a stimulated cycle with a natural cycle in the next 1 to 4 to 5 months. Please remember that we're talking about poor responders here, and it's not a matter of providing one isolated treatment. I ask my patients to give me perhaps 4 to 6 months in order to maximize the potential possibility of retrieving as many eggs as possible.
Okay. Thank you, Dana, for your question. I hope that was useful. I do believe so. And let's have a look at the next question. Is there an advantage, disadvantage of PRP versus Sanakin ACRS? I'm sorry, that's the first time I see it, so
yeah, that's fine. Yeah, this is autologous cytokine-rich serum. Nobody knows. Nobody knows. My team and I were studying this method. We're looking into the evidence. We're discussing with scientists all over the world. I do not have the answer. If I were to answer that, we're not using that technique at the moment because we're not convinced. I believe that may be the next step, or may be a combination of those two steps. I think we're scientifically quite far from comparing head-to-head the two treatments. If I were to choose one, I would probably go for the traditional, although still the jury is out for PRP, but I mean, for cytokines, I think we're a little bit further away from having evidence.
All right. Thank you. Thank you for that question as well. All right. Let's see. Next question here. There seems to be an improvement in AMH and AFC. Any studies or personal experience at your clinic showing the improvement in egg quality, higher euploidy rates in IVF cycles following PRP?
Sure. Answer is no. Clear answer is no. There's no evidence. However, given the number one denominator, the number one factor for egg quality is female age. So this doesn't change with PRP treatment. However, what changes, hopefully, is the ability to retrieve, on average, one more egg. One more egg in a poor responder is a huge improvement. I don't believe it happens every time. I'm not saying that each time any of you would have PRP treatment would have the luxury of having one more egg. I don't think this is the case, and this is for various reasons. However, if we select our patients carefully, if we are happy with the procedure, as I said, I'm very happy. I mean, my team and I think we've reached a very good point of producing good quality PRP. We have invited, actually next week, we're waiting for an amazing colleague from Sweden to come and visit us, and we're very happy to share little secrets. They're not secrets, us scientists, we discuss with each other, we converse, we value each other's opinion and each other's experience. And in October, we're having a wonderful team from Serbia coming to be taught how we do the PRP treatment. So I believe that if done properly in a select group of patients, I think there is value. And now, if it's, I invariably discuss and invariably perform it. Also, when I do a laparoscopy on a poor responder or on a woman with advanced reproductive age, 38, 39 and above, if I do laparoscopy for any other reason, most of you will probably know that I'm one of the old dogs. I really like laparoscopies. I believe that there's a lot of information we get from laparoscopy, and we shouldn't be forgetting that, starting from the possibility of diagnosing, treating, or even excluding endometriosis. And then if we do PRP in the course of diagnostic laparoscopy, in our hands at least, has been much more effective than the vaginal route and so forth. So it's not for everyone, but I think for the generally younger population, or for a select group of advanced reproductive age, may be of benefit. I'm waiting to see the results. I mean, there are some people in the world working on, it's not us, working on the perimenopausal women, in order to, not for fertility purposes, but for well-woman benefits. If they can prolong the period, even if the eggs are not of good quality, that may be beneficial also. So I will not be surprised if PRP treatment, it may find an indication for treating perimenopause sooner than for fertility.
Okay, interesting. Again, thank you so much. And what is the oldest age of women succeeding with a positive test after PRP? Are you able to tell us?
Yeah, there's a lot of case reports out there. If I remember well, the spontaneous case report pregnancies up to the age of 46. But there's a lot of cases, a lot of case reports out there.
Right. Okay, thank you. Thank you. If it's not a secret, may I ask how much does it cost at your clinic?
Well, to be honest, this is a red line. I'm sorry, I cannot disclose prices online. However, if I mean, for various reasons, and legal department is very strict on that. But by all means, if any of you wishes to have an individualized quote, depending on the circumstances, feel free to send us an email. Please quote that you saw us here to make sure it's all legit and all that. And by all means, we will send you a quote.
Perfect.
I've just typed our email.
Sure. Perfect. That's always helpful. All right. Okay. Thank you so much for that. And let me show you this question. Not sure here. So my wife has PCOS. Last 6 months, she went through IVF. Are there any complications? Like you can see here, I'm not sure here, but this is the message we've received.
Yeah, sure. I understand the message. I mean, it's not, it doesn't have to do with PRP, but I'm more than happy. Kemal Abdella, hi. I'm very happy to answer that. The complications associated with PCOS are not so much linked with IVF as they are with the PCOS itself. And the answer, unfortunately, is yes. There may be higher chance of gestational diabetes and pregnancy hypertension. However, since you have diagnosed the PCOS with appropriate measures before conception, ideally, but during pregnancy also, you may minimize that risk. And the vast majority of PCOS ladies in pregnancy, they do extremely well.
Okay. Thank you so much indeed. Once again, I do hope that was useful. If there's anything else, you know what to do. Go ahead. And Dr. Tsakos, I'm sure you see that question in it's in French, I believe. So
yeah.
I don't understand that, but I was able to simply translate this right here. So the question is, so in the first month, the patient already had gone through PRP. In the first month after my PRP treatment, there was a good improvement in LH and FSH, but AMH has not yet increased. How many months do I need to wait to see the expected result of the treatment? Sure. And can I repeat it?
Yeah, absolutely. Look, thank you so much. I mean, I was reading this French message. I can read French, but I cannot speak very well. So I think it's positive that LH and FSH presumably have dropped, so they have improved. In my opinion, the biggest denominator of success is not so much the figures, but the response to stimulation. So, in my experience, the peak comes at 3 months, 90 days. So I would do stimulations, alternating perhaps. I would do minimum mild stimulations, alternating with natural cycles. So mild stimulation 1 month, natural cycle next month. This is my protocol, and I would aim to collect one or two follicles, one or two eggs in its cycle, and then hopefully have 2 to 3 good quality embryos, and then do frozen embryo transfers one at a time.
Okay. Again, thank you so much. And if you have more questions, you know what to do. Go ahead, type those in. We will still have a few minutes, so go ahead and type those in. And in the meantime, of course, I do receive very often questions in regards to the AFC. If it's 0, antral follicle count, if it's 0, can the PRP ovarian rejuvenation can PRP be performed for someone like that?
Sure. I mean, first of all, AFC is very good, it's very important, but it is one factor. And please remember that AMH was discovered in order to be much more objective than AFC. I have to mention here that my team and we were amongst the very first in the world who studied AMH, and that was we started our studies in 2008. And we very proudly presented a couple of papers, some very high impact papers, that are being quoted at the moment in the ovarian stimulation protocols by the European Society of Human Reproduction, by 𝐟𝐨𝐫𝐿. And actually that study led to a PhD for one of my colleagues. The reason why I'm saying this is that overall, AMH is more likely to be correct than AFC. That was the bottom line of our studies at the time. And why is that? Because it's the value, the accuracy of AMH is more likely to be correct than the value and the accuracy of AFC, because AFC requires technology, scanning technology. It's very subjective. It may vary depending on the timing of the cycle, and of course it's very variable depending on the piece of equipment we use and the experience of the doctor who uses the equipment. So yeah, it wouldn't surprise me. For me, the factor, for example, AMH, I wouldn't. If somebody has 0 AFC, they should not be having periods. So if they're not having AFCs, if they don't have follicles, they can't have periods. So if somebody is having a period, it's very likely that they have small follicles as well. Mm-hmm. So I like to look at everything collectively. Mm-hmm. And don't forget that before treating anything, whether it's your pale skin because you think you have anemia, or before you take vitamin D because you don't think you've been exposing yourself to the sun, test first. I'm a huge believer of testing. And we're not talking about the laboratory tests. Test yourselves first in order to understand what you need. So if, for example, if a lady in her 40s, she's having a period, even a short cycle or a longer cycle, she's very likely to be having AFCs and to be having follicles. And of course, PRP is never a first-line treatment. I mean, for me, the biggest test of ovarian reserve is the response to stimulation. Mm. So if you haven't had a stimulation before, have a stimulation, mild stimulation. You don't need to strap your foot on it. Mild stimulation, 150, 200, 250 units, mild. We all know too well, I mean, the ones of you older than 37, 38, if you've had IVF anywhere in the world, you were probably given 450 units daily. I don't agree with that personally. I don't think, and I have presented on that various times. It is giving us a temporary relief as doctors and you as patients. And yes, we see a lot of follicles. On the day of egg collection, we're very likely to at least take 1, 2, or 3 eggs. So we take 1 or 2 eggs extra. But on the day of the embryo transfer, the number of good quality embryos are exactly the same, whether we stimulate with 450 or with 250. And then we have wasted so much drugs. We have financially, we have been drained. We have bombarded our bodies with drugs for no reason. There's no benefit with high doses. So especially with poor responders, which is of course the subject of today's presentation, there's no point whatsoever in using huge doses of gonadotropins.
Mhm. All right. Thank you so much. And in the meantime, we did receive one more question, so we will have a look at this. If you have more, you know what to do. And the question is here. So age 39, history of IC, pregnancy loss, and stage 4 endometriosis. Is AFC 47 a very low number? Is it considered diminished ovarian reserve? And should I go ahead with PRP?
Yeah.
Anything you can advise?
Sure. I mean, Roy, AFC of 7 at 39 is wonderful. I would never do PRP unless I'd done a stimulation before to see what's going on. You know, PRP, in my opinion, is the last resort before egg donation. So despite your endometriosis, despite your age, which is 39, an AFC of 7 is a very good AFC. So in my opinion, optimize your health. You know, don't go to have IVF tomorrow. Optimize your health, exercise, vitamin D, protein, avoid sugars, no alcohol, no smoking, good thoughts, good mindset, positive thinking, hang about with wonderful people with positive energy for a couple of months. You know, take some folic acid, and that's it. Go and then go for a stimulation. You know, have a standard stimulation. Go for a standard protocol. If your BMI, if your weight is normal, 250, 300 units is more than enough to start with. Go and have an egg collection, hopefully collect 5 eggs, 4 to 5 eggs, hopefully create 2 to 3 embryos. Your chance of success in good hands is more than 50%. That's my opinion. You know, as long as you produce a couple of eggs, a couple of good quality eggs at least, a couple of good quality embryos, you don't need PRP.
All right. Thank you so much. Looks like it's that was our final question. If you have more, we still have time. Go ahead, type this in. Someone is typing, so let's give it a minute. Let's see if you have more questions. But as you can see, there are some thank yous coming your way as well already. So
Sure.
thank you for those comments. And yeah.
Before you go, thank you so much. I mean, it's I've always you know, a lot of people ask me, I mean, why do you do webinars at 10 in the evening? It's 9:45 in the evening in Greece now. Today we started egg collections at 7 o'clock in the morning. We've done a lot of work. We had beautiful couples and single ladies coming from all over the world. I even had a Skype today with a Mexico lady. That was amazing, lady from Mexico. So what I'm saying is that through those webinars, Caroline and the whole team behind the scenes, we learn a lot. So there's a little bit of a selfish factor there. I learn a lot. I went through the literature in the last few days. I made some updates. I was designing the slides, and I was trying to not exactly sit on the fence. I believe what PRP, but I think we don't know exactly you know, which is the ideal candidate for that. Perhaps some women would do it unnecessarily. Perhaps some women who would benefit, they're still in the shadow. But the reason why I'm doing this is I'm learning a lot. I'm learning from you. I'm learning from the need to learn in order to share. And I'm very grateful for this. Thank you very much. I think we're in 2025. You all deserve to know. You all deserve the latest piece of knowledge and science. Please excuse us. We don't know everything. There's more that we don't know than we know, but at least we know what we don't know, which is always a good thing. And please keep sending questions, keep challenging us, hang in there and never give up. The vast majority of you will become parents, and I think the world needs that, and we need you as much as you need us. Thank you very much.
Thank you so much indeed. Before we actually finish, one more question I think I missed. Sorry about this, but here it is. So I just wanted to know if we can try naturally after PRP at 43. Of
course, provided that you haven't been trying naturally forever. You have a short, relatively short duration of infertility. The longer you try, the less the chance there is. Provided that you have checked the essential factors like sperm, semen analysis. I have to stress here that sperm is not just a semen analysis. It's definitely also a culture and perhaps a DNA fragmentation index, because there's more and more evidence showing that this may affect natural conception. Initially, we thought that it affects only natural conception and IUI. Now we know that it may also affect 𝐃𝐨𝐬𝐫 and IVF. So as long as you have tested for the basic factors, and of course the woman has been tested for tubal patency, and also very importantly that she has had a high quality 3D, 4D ultrasound scan. If you allow me 30 seconds, the majority of the scans we do for women perhaps are inadequate. A standard transvaginal scan with a standard piece of equipment by a standard ultrasonographer or a gynecologist is not enough. The technology of 3D and 4D ultrasound diagnostics is amazing. My team and I will have published very, very beautiful papers comparing not only 3D, 4D scans with standard scanning, but also with MRI scanning, with magnetic resonance imaging, and they seem to be superior. So I've had a normal scan with no images, no 3D, doesn't really mean very much. So please insist on having more advanced tests. So provided you've done all that, by all means, natural fertility is also improved, of course.
Okay, thank you so much. And once again, we did receive another question. So age 36, AMA 0.8, 3 miscarriages, should I do PRP?
Probably not, Alexander. I mean, PRP, I mean, I would investigate your miscarriages. You know, investigate the miscarriages. Hormonal, genetic, infection, anatomy, and don't forget the man. Don't forget testing your man. Okay, if you need some more, by all means, send us an email. I will send you the list.
Definitely, that sounds great.
Before you go, for any of you who wanted a second opinion, an informal, a formal, whatever level we can be of help, please don't hesitate to email us at info@embryoclinic.eu. Please send us the relevant information. I have the most amazing international department. They pick up the mail and they can set up a wonderful video call. Within 30 minutes, I'm sure we can be very individually helpful.
That sounds amazing, and I think that's always best to do. That way, you know, you can get a proper answer with all the details. So thanks a lot for today, everyone. And of course, if you have any questions, as Dr. Tsakos said, you can definitely get in touch, and we are also always happy to forward any messages, so you can also send those to me. Thank you so much, everyone. I'm really happy to see that it was helpful, and we are always happy to be here and help as much as possible. Dr. Tsakos has been our guest speaker, and of course I'm sure we will have some more events shortly. So have a lovely evening, everyone. Take care, and hope to see you here as well, and I'm sure you have more questions. Take care. Bye.
All the best. Good night. Bye-bye.